Hello, everyone. Welcome to the Glaucoma Lecture Series number 3. Today's topic is on primary open-angle glaucoma. This topic is being presented by MediTread, a leader in online training and education. I am Ramesh Ayala from Tulane School of Medicine, New Orleans, Louisiana. Here are my financial disclosures for the sake of completeness. So today we'll go through a brief history of glaucoma, where the word came from, who are the key players in the classification of glaucoma, followed by primary open-angle glaucoma and various stages of it, and we'll end with the discussion of the risk factors associated with primary open-angle glaucoma. So the word glaucoma implies greenish or bluish hue, or a dull sheen or glaze of blindness. In the Hippocratic aphorisms, glaucoma was used to describe blindness coming in advancing years associated with the glazed appearance of the pupil. The classic description in those days was, if a pupil becomes sea-colored, sight is destroyed and blindness of the other eye often follows. I'm guessing that when they use this description, they're describing the searching motions of a blind eye from glaucoma. If you ever watch this in a blind patient, they'll have the searching look towards the sky, and you can see that the light plays a little trick on their cornea and the pupil, and you can see a slight haze on the cornea, and the light reflects from the pupil. It will be more of a bluish green color discoloration, and so someone in those days have they recognize this phenomena being associated with blindness, and as is written here correctly, this glaucoma, blindness in the other eye follows in the near future, and so they recognize that glaucoma is a bilateral disease process. Having said that, they did not identify glaucoma as a separate entity at this point. The glaucoma and IOP, the association between intraocular pressure and glaucoma was first made in the 10th century by this guy at Tabari, who's from the Middle East, and he described a chronic inflammatory condition of the eye with raised tension. And in 1348, this gentleman by the name of Samsadin, I think is the right way to say it, described migraine of the eye leading to blindness, and I have to assume that he means acute glaucoma when he describes migraine of the eye leading to blindness. Now it was left to Richard Bannister in 1662 from England to describe the end-stage glaucoma as a combination of tension, i.e. elevated intraocular pressure, chronicity, meaning the disease process is chronic, no light perception or NLP, and a fixed pupil. And in 1888, De Morris described the color of rainbows in association with the high eye pressures. Now remember, till this day, they had no idea between acute angle closure glaucoma and open angle glaucoma. That came almost a century later. But De Morris, to his credit, associated patient description of rainbow colors in association with his high pressures, and is describing there an acute attack of glaucoma. So fast forward to 1854, the next major evolution in the history of glaucoma goes to Von Graffe and Jagger. Both of them, within a few months, I believe, described the appearance of the optic nerve head in a glaucoma patient, and with the direct ophthalmoscope that was recently invented at that point in time. And they both thought that glaucoma optic nerve head actually is not cupped, that it was swollen. So the initial description of glaucoma nerve head was a swollen optic nerve head. And that's a limitation of the optics of the direct ophthalmoscope that they had access to in those days. So no lecture on glaucoma would be complete without showing you a picture of Von Graffe, brilliant scientist, ophthalmologist, and from all my readings, a great guy altogether. He unfortunately passed away at the age of 40, I believe 42 or 44, and this is his statue in the charity hospital located in Berlin, which as I understand it, is still standing, survived World War II with very little damage. Now, the interesting thing about the way this this statue is built, you can see in his right hand he has the ophthalmoscope right there, and his left hand is resting on the chair, and on his right here are patients suffering with eye conditions, and on the left are patients who have undergone surgery by Von Graffe and have been relieved of their pain, and so they're rejoicing. Now, beautiful thing, Von Graffe is one of the finest surgeons that ophthalmology had the pleasure of knowing, and he has devised one of the first glaucoma surgeries that was very effective, i.e. iridectomy, without realizing why it worked. Until today, iridectomy, when performed in a patient with acute angle closure glaucoma, is curative, and he described this in mid-1800s. So next time you guys go to Berlin, look up this statue of Von Graffe in Charity Hospital. So Von Graffe, the reason why I showed you this picture of Von Graffe before I went into classification is because Von Graffe was the first guy in 1857 to describe a classification of glaucoma as acute, chronic, and secondary. And at that point in time, he still thought it's caused by serous choroiditis. That was the prevailing theory in 1800s. And he called simple glaucoma, i.e. the open angle glaucoma that we talk about at the present time, as excavation of the optic nerve as a distinct entity. Donders in 1862 was the first to recognize simple glaucoma, or what we now call as a primary open angle glaucoma. And in late 1800s, glaucoma was classified as primary glaucoma, as one, chronic simple glaucoma, which is the primary open angle glaucoma, and two, the congestive glaucoma, which has been subclassified into acute, chronic, and absolute glaucoma. When they talk about congestive glaucoma, what they refer to here is acute or angle closure glaucomas, which go through, as we all know now, go through the different stages. So these people are excellent clinicians, and they observed all these stages, the natural history of progression of this glaucoma, different kinds of glaucoma in this patient population. It's because they did not understand the pathophysiology behind this and the mechanism of glaucoma, they were kind of restricted at that point in time. But still, hats off to these guys for their clinical observations and the way they classified glaucoma, which is pretty accurate till today. But of course, it was left to this gentleman by the name of, let's see, why am I getting this? No, that's not what I wanted. Undo. Okay. Okay, so it was left to Otto Barkan, an American practicing in Stanford University in 1938, using his gonioscopy skills to describe glaucoma as wide or open angle and narrow or closed angle glaucoma based on his gonioscopic observations. He also is is famous for a couple of other things. One, he established the concept of acute glaucoma. He made gonioscopy popular. He introduced goniotomy procedure for congenital glaucoma, which till today happens to be the #1 surgical procedure for congenital glaucoma. And so I think I need to show you a picture of Barkin, because no lecture on glaucoma will be complete without a picture of Barkin. This is Otto Barkin, 1887 to 1958, practiced in Stanford, San Francisco. He is of Hungarian descent, as I understand, studied in Oxford, England, and practiced in Stanford, as I mentioned. And he was very passionate about angle anatomy and spent a lot of his life studying the angle anatomy. And he was the first one to describe the classification based on open and closed angle. And also, as I mentioned, goniotomy is a treatment for congenital glaucoma. Great guy. So let's come to the present day classification as we understand it now. Since science has progressed from those days, we broadly classify glaucoma as open angle and closed angle, and each variety is again divided into primary or secondary. The open angle glaucomas is again subdivided into primary open angle glaucoma, i.e. glaucoma that is not associated with any known association of either within the eye or systemic association leading to glaucoma, low tension glaucoma, pseudoexfoliation syndrome and open angle glaucoma, pigment dispersion and pigmentary glaucoma, and open angle glaucoma. Today's topic, we're going to limit ourselves to primary open angle glaucoma. Okay, POHE, or primary open angle glaucoma, is a diagnosis of exclusion. You have to exclude every other condition before you label the patient as primary open angle glaucoma. In this part of the world, primary open angle glaucoma is the most common variety of glaucoma that we see, and it's based on intraocular pressure measurement, elevated intraocular pressure, open angles at all times. So gonioscopy is a must. You have to do gonioscopy to make a diagnosis of open angle glaucoma. Optic nerve changes that are characteristic of glaucoma, which we'll go through and which we have covered in the previous lectures, and characteristic vision field changes. And there will be a lecture forthcoming in the near future on vision field. So the must-do things when you examine a patient with glaucoma: one, pachymetry to measure the thickness of the cornea. As you all know, the thickness of the cornea has some bearing to the intraocular pressure measurement. The technique that we most commonly use still the Goldman, and we all know now that the cornea thickness contributes to the variations in the intraocular pressure as we measure it. And gonioscopy, which will decide whether the angle is open or not. All patients of primary open angle glaucoma by definition should have open angles. Intraocular pressure, elevated intraocular pressure is the leading cause for optic nerve damage, and optic nerve exam to demonstrate damage to that optic nerve. So every patient with glaucoma, I expect you guys to do all of these things. There is no way you can complete your examination of glaucoma without this. So glaucoma, primary open angle glaucoma, when you examine these patients in the clinic, I will show you some examples as to how we classify them. We classify them either as a glaucoma suspect, ocular hypertension, mild, moderate, or severe open angle glaucoma patients, right? And so we'll go through each one of them with an example from my own practice. So how do you define a patient as a glaucoma suspect? The appearance of an optic disc or retinal layer that is suspicious for glaucomatous damage without vision field defects. These patients may or may not have elevated intraocular pressure. So here is a patient in my own practice, 55-year-old female diagnosed as a glaucoma suspect, best corrected vision of 20/20 in both eyes, pachymetry normal at 530 and 540 microns. Intraocular pressure was 17 millimeters of mercury OU. She was on no medications, and angle was completely open on gonioscopy. Here is what we're talking about. If you look at this picture here with magnified optic nerve, you can see that the cups are slightly asymmetric. You can see that this cup here is much bigger compared to the size of the cup in this eye. And so based on this cup disc asymmetry, the patient was called as a glaucoma suspect. And of course, the patient had visual fields which were found to be normal, the right and left eye, as you can see here, and an OCT of the optic nerve head, which was also found to be normal. The retinal nerve fiber layer thickness, as you can see here, is okay, as you can see here, is completely normal. It falls within the green zone, telling you that it's normal. And the readings here at 92 and 95 micrometer thickness it falls within the normal range. And so we know that the RNL and retinal nerve fiber layer thickness is normal. And so here is a classic example of a patient who is a glaucoma suspect. So the goal of treatment for these glaucoma suspects is to detect glaucoma-related optic nerve changes early enough by careful and frequent observations. When we say frequent, you don't need to see them like every 2-3 months. Once or twice a year is all that we do. When a patient with glaucoma, as a glaucoma suspect, is referred to my practice with large cups, asymmetry cups, I tend to see them do all these investigations that I just mentioned, and then see them back in about 6 months. If there is no change, I'll follow them every year and repeat the test. And one of the keys here is to observe the optic nerve ever so closely and monitor the intraocular pressure. It may increase with increasing age, and also when there is a doubt, there is a role for serial tonometry in these patients. And one thing that I did not mention here is the optic disc. The disc has to be examined on every single visit using your 90 diopter lens or 70, 76, whatever stereo lens that you have access to at the slit lamp. Please take the time to examine the optic nerve head to make sure that it's not getting worse in leading to glaucoma. Since you can detect early glaucoma at this stage, you will prevent blindness in the future for these patients by starting treatment early. So how do we manage these patients? Like I was mentioning, 6 monthly careful observations, IOP, stereo, disc exam, OCT, and swab. Medical management, as seen with is similar. If you do detect that the glaucoma suspect is developing glaucoma, either by elevated intraocular pressures or early disc changes by one of these various techniques, then the treatment would be similar to somebody with mild glaucoma or ocular hypertension. Let's move on to ocular hypertension. So by definition, elevated intraocular pressure is greater than 21 millimeters of mercury in the absence of an optic disc or retinal fiber layer abnormality that is suspicious for glaucomatous damage or vision field defects. So these patients have elevated intraocular pressure and nothing else. Of course, when we talk about 21 as the cutoff point here, why 21? Historically, the average intraocular pressure in population-based studies, as we all know, is 16 millimeters of mercury plus or minus 3. So what they did was to take the outer limit of this, and then they we all know that when the pressure hits 21 or higher, the likelihood of developing glaucoma is much higher. And so that's the commonly used cutoff point. Some people say 22, 23. But the important point is for you to get this concept that at a certain point, above which we call these patients as ocular hypertension. This is a distinct entity in itself, separated from glaucoma, which, as we defined in the first lecture, at the present time is defined as an optic neuropathy. Granted, it's an optic neuropathy, but one of the main factors that lead to this optic neuropathy is ocular hypertension. So they're intimately interlinked any which way you look at it. So if you have a patient with intraocular pressure greater than 21, and there is absence of optic disc or retinal nerve layer loss or damage, vision fields are completely normal, you classify them as ocular hypertension. So here is a patient in my own practice with ocular hypertension. Vision 20/20, intraocular pressures in presentation were 24 in the right eye and 26 in the left eye. Pachymetry was normal at 543 and 540. He was on no medications, angle completely open and gonioscopy. And as you can see here, optic nerves are completely normal. In fact, these optic nerves have very small cupping, as you can see here. There. And the vision fields are normal. And so is OCT with normal rim and a normal retinal nerve layer thickness. So the target here in terms of treatment is to reduce the intraocular pressure by 25% from the baseline intraocular pressure. Some ophthalmologists prefer setting the target to be less than 18 millimeters of mercury. Now, everything that you do when you start treating the patient, there has to be some common sense involved in it. So don't ever treat a patient by definitions used in my lecture or in any standard textbook. Based on other factors, whether the patient has multiple allergies, whether the patient can tolerate the medications, whether the patient can afford the medications or the treatment that you're offering, etc. A lot of other factors come into this. But remember, as a general rule, what you want to aim for is a 20 to 25% reduction in intraocular pressure. So how do we do this? Medical therapy versus SLT or ALT is the first line intervention to lower the IOP unless contraindicated. Okay, so the American Academy of Ophthalmology preferred practice patterns mention that prostaglandin analogs and beta blockers are the most frequently used first line eye drops for lowering the intraocular pressure. Prostaglandins, by and large, have been shown to be the most effective drugs at lowering IOP and should be the initial medical therapy unless other considerations such as cost, side effects, or intolerance preclude this. What does that mean? Latanoprost and its sister drugs are the #1 choice because they have the least side effects. They're used once a day. Very easy for the patient to remember to use it more at bedtime. And they have a 25% reduction in intraocular pressure, up to 30% in some patients, reduction in intraocular pressure. So they're very effective in doing this. And so I would suggest that using the prostaglandin is a great way to start these patients on. And so is SLT. Now remember, one problem with prostaglandins is cost. Here in the US, it costs anywhere from $60 to $80 depending upon where you buy this medication. Whereas if you choose to do a beta blocker such as timolol, it costs you like $3 in Walmart. And in different parts of the world, I'm sure the cost is still a factor. And so based on your patient's social background, you need to choose a therapy. Now, one other option that you have that you can discuss with your patients is SLT or laser trabecoplasty. It's the laser trabecoplasty trial that compared laser versus medical treatment showed equal effectiveness as a primary mode of treatment in patients with ocular hypertension and mild glaucomas. So yeah, it's okay for you to talk to the patient. Patient is willing. You should try and do the ALT. It's a one-time deal. Takes less than 2 minutes, and we will have a discussion as to how to perform SLT or ALT in the later talks. And if it is found to be effective, which it is in 75 to 80% of the patients, then the patient is spared the continuous cost of medications and also the nuisance of remembering putting in the drops on a daily basis, right? So one of these two things is what I would suggest, either a prostaglandin analog such as latanoprost or sister drugs, or a beta blocker if a cost is of consideration, or you can use the ALT or SLT as a mode of treatment. Let's move on to the next step in this progression of primary open-angle glaucoma. This is mild primary open-angle glaucoma. How do you define mild? An appearance of the optic disc or retinal nerve fiber layer that is suspicious for glaucomatous damage, and a vision field suspicious for minor glaucomatous damage correlating to the location of optic disc or retinal nerve fiber layer damage in the absence of clinical signs of other optic neuropathies. So damage such as paracentral scotoma or early arcuate bundle defect, nasal step, altitudinal defect in the early stages, or a larger mean pattern deviation, any of these will fit into this definition of mild primary open-angle glaucoma. The reason why we are classifying this is the treatment is slightly different. It tells you how aggressive or you have to be in correcting the intraocular pressure, which is the only modifying factor that we have for glaucoma in terms of treatment. And B, as the ICD-10 gets into effect, you have to define the stage of the glaucomatous disease process as part of your billing also, and diagnostic description also. So you may want to follow this for those purposes. Here is a patient in my own practice with mild glaucoma, primary open-angle glaucoma. His NLP in his right eye for secondary to trauma, best corrected vision 20/20 in the left eye, pachymetry 540 OU, intraocular pressure was 27 in the left eye. He was controlled on 2 medications, Cosapt and Xaratan, angle completely open and gonioscopy. So here is the left eye optic nerve, and as you can see here, the cup is fairly well defined and large, and maybe occupying, like I said, 0.75 or so. And you can, on the vision field examination, you can see very early optic nerve, visual field changes. So it's something that you need to be aware of when you examine these patients, and you can see the OCT revealed thinning of the retinal fiber layer down to 49 or so. Now, one thing you have to be careful about with the OCT is that the retinal fiber layer thickness does not always indicate glaucoma, but given other factors, it does support the diagnosis of glaucoma. In a patient with the elevated intraocular pressure, such as this particular patient at 27 millimeters of mercury, and OCT that is at 49 microns thickness of the retinal fiber layer, I certainly would consider starting treatment on this particular patient, even if the vision fields did not show any change. So the target here is below 20, around 18 or so, 18 or less, especially given the fact that this patient has only one eye. Medical and laser options are available to meet the target intraocular pressure, meaning that this particular patient could be treated either medically, like we are doing now with Cosapt and Xaratan, to bring the pressure down to below 18, or you can add or top it off with laser treatment as well, ALT. There is certainly no indication at this point for us to consider surgical intervention. If the glaucoma progresses a little bit more, we call that as moderate open-angle glaucoma. Here's how it's defined. Optic nerve abnormalities consistent with glaucoma as discussed above, that is the mild version, and vision field abnormalities in one hemifield, i.e. arcuate scotoma, that are not within 5 degrees of fixation as tested with standard automated perimetry. So here is an example of that. Here is a patient who is NLP in the right eye, status was Strabo U 1988, diagnosed with moderate primary open-angle glaucoma in his left eye. Intraocular pressure in left eye presentation was 42. Medications none. Intolerant to a lot of drops. Angle completely open on gonioscopy. And here is his left eye optic nerve head appearance. As you can see, there is a fair degree of cupping that is visible. And visual fields that suggest superior arcuate scotoma, and the OCT showing thinning of the retina of a layer. Here is another example of a patient. So in a 87-year-old diagnosed with moderate glaucoma in the left eye, which has progressed to severe glaucoma. So presentation, intraocular pressure was 30. Following treatment, his pressure dropped down to like 15. He was on 3 drops, Cosapt, Alfing, and Zalatan. Gonioscopy was open on open angles, and you can see that his optic nerve is completely blown out in this situation. When this picture was taken, this was a picture of his vision fields that were done 6 years prior, and you can note that the vision field loss is restricted to superior arcuate scotoma. Over the last 6 years, by the time the patient was referred to us, he had lost some significant vision field, progressing on to the inferior quadrants too, and it tells you worsening vision field. In this particular setup, what would you do when the patient is referred to you? Obviously, you want to lower the pressure as low as possible, like in an advanced open-angle glaucoma patient, and that means lowering the pressure close towards 10 millimeters of mercury. So the target in patients with moderate primary open-angle glaucoma is below 15 millimeters of mercury, and it could be achieved either with medical treatment or surgery. The 2 cases that we presented both underwent uncomplicated trabeculectomy with IOPs below 15 on Cosapt. So I tend to be aggressive in these moderate open-angle glaucoma patients. Generally, if medications don't bring the pressure down and I observe fixation is being threatened, I don't wait and try other medications. I would rather do a glaucoma procedure such as trabeculectomy and bring the pressure down below 15, and that way hopefully the progression of the disease process could be arrested. Let's move on to severe primary open-angle glaucoma. It's defined as optic nerve condition with optic nerve abnormalities consistent with glaucoma as detailed above, i.e. the descriptions that we just gave in the previous slides, and vision field abnormalities in both hemifields and or loss within 5 degrees of fixation in at least one hemifield as tested with standard automated perimetry. Some ophthalmologists consider the glaucoma to be severe when they're double arcuate scotomas. So here is an example, 75-year-old female diagnosed with severe glaucoma, 20/20 vision in both eyes, intraocular pressures of presentation 30. Following our surgical intervention, the patient's intraocular pressure is at 8 millimeters of mercury OU. Presentation medications include Cosapt, Alfing, and Zalatan, gonioscopy wide open angles, and here you can see that the cup is completely cupped out optic nerve, almost 100%. You can see very little rim that's left in this area, and maybe this area. Follow the blood vessels. When you look at these optic nerve heads, that gives you a clue as to how bad the glaucomatous cupping is. You can see that these blood vessels, if you trace them, they're dipping, and where they come out is where the cup ends. if you follow these blood vessels, there is almost no rim at all left in this optic nerve. Same thing on this side, maybe slightly better. There's a slanting edge to this, the way this blood vessel exits, indicating that there may be a little rim there. But look at this severe vision field loss in both eyes. This is double arcade scotoma with even fixation loss in this right eye, and in the left eye there is a small paracentral 10-degree, 15-degree area through which the patient is still seeing 20/20. I mean, when you look at this kind of vision field and then they still see 20/20 in the clinic, it makes you wonder. You know, with the few cells that the patient has, they're still able to see this. And these are the kind of patients that you got to be really careful. One spike in their pressure to 30s or 40s, it's going to knock out their vision. And so it's extremely important that when you operate on these patients, keep the pressure low, make sure that there is no pressure spike at any point in the follow-up period, follow these patients ever so closely, and make sure that their intraocular pressure so below 15, close towards 10 at all time points. If you can do that successfully, these patients can retain some useful sight and at least to lead a independent life. Now, OCT of this particular patient, as you can see, the retinal layer is thinned out. And of course, in these kind of patients, like I mentioned, target intraocular pressure is 10. How do I manage these patients? I don't play around with medications with these patients. I take them to surgery, operate on these eyes, and achieve the intraocular pressure that I have in mind, with the help of medical medications if necessary after the surgical intervention. So it's kind of interesting. It's never been written in such a way in literature, to my knowledge, but in my own practice, when I do these glaucoma procedures, almost any procedure that I do now, I do different kind of procedures I offer to different stages of glaucoma depending upon what the target intraocular pressure that I have in mind. For example, in this particular patient, the target pressure is 10. This is a dictum, by the way, of Chandler Grant when they came out with this paper, classic paper that we'll discuss briefly towards the end of this lecture, that patients with optic nerve damage, significant optic nerve damage, should receive, the treatment should result in lower intraocular pressure than the normal accepted intraocular pressure, i.e. 16. So what you want to do, what they're trying to tell you is that when a patient presents to you with advanced optic nerve damage, even a pressure of 16, which is normal for everyone with no glaucoma, is still abnormally high for these patients, for that particular optic nerve. And so you got to lower the pressure as low as possible. The lowest that we aim for is about 10, so plus or minus 2. So that's what you need to aim for in these patients. So following what I was trying to say is this: you would do trabeculectomy operations on these patients. About 60% of them will have the target achieve the target intraocular pressure with no medications. About 40% of them end up with additional glaucoma medications on top of a successful surgery to achieve this target intraocular pressure. That's it's been that way in my practice for a long time. As I look at my own surgical data, I see that about 40–50% of the patients end up on topical medications following surgical intervention to achieve the target pressure. So those are the various stages of primary open-angle glaucoma that you will encounter. So what are the risk factors for somebody to develop primary open-angle glaucoma? We're going to briefly go over this in the interest of completeness of the lecture, but I have to mention that you should listen to the part 1 of this lecture series in glaucoma, wherein I spent some significant amount of time discussing these risk factors. So elevated intraocular pressure, as I mentioned at the very beginning of this lecture, is the #1 risk factor for someone to develop primary open-angle glaucoma. Older age, as we age, the risk of developing glaucoma increases. A family history of glaucoma, African ancestry or Latino Hispanic ethnicity, thinner central corneas, lower ocular perfusion pressure, type 2 diabetes, myopia, and genetic mutations are all known to be risk factors for POAG. What's the pathophysiology? I covered this extensively in my glaucoma lecture series number 2. Essentially, there is here is the ganglion cell, here is the axon, and here is the brain, the lateral geniculate body, and at the level of the lamina cribrosa, there is an obstruction to the axonal flow leading to ganglion cell death, which in turn would lead to vision field loss in that particular area. Now, whether it's a mechanical or a vascular or a neurological or a combination of all of them is still debated, but enough to know at this, as part of this lecture, that the exoplasmic flow is compromised in this patient population, leading to axonal and ganglion cell death, which in turn will lead to loss of vision. So the only modifying factor among all of this is the elevated intraocular pressure. We don't know how to resuscitate the ganglion cell or reestablish exoplasmic flow in this patient population. The only way we know how is to reduce the intraocular pressure, and which in turn will relieve the pressure effect on the exoplasmic flow and maybe the blood circulation to the axons, which in turn will reestablish the vitality of the ganglion cells. Now, the purpose of this slide here is the optic nerve versus trabecular meshwork in glaucoma, to highlight the optic nerve glaucoma versus the trabecular meshwork in glaucoma. David Epstein, I strongly recommend every one of you who are interested in glaucoma to go through the Chandler Grant textbook, the latest edition, a wonderfully written textbook, and Dave Epstein has a special column in one of these chapters on primary open-angle glaucoma there, where he talks about optic nerve glaucoma versus trabecular meshwork glaucoma. And I think what he meant there is whether glaucoma, whether the primary etiology is at the level of the trabecular meshwork, wherein there is an obstruction going on here and to the outflow pathway mechanism leading to elevated intraocular pressure, and this in turn causes damage to the optic nerve, or there are some sections, subsets of population where the optic nerve is susceptible to damage from even normal intraocular pressure, the so-called normal tension glaucoma or variants of the same. So there, and again, in clinical practice, you will see patients. I recently saw a patient who had intraocular pressures documented greater than 30 to 40 millivolts of mercury for almost 50 years. His optic nerve is still intact. If only I know how and why that optic nerve withstood that elevated intraocular pressure all these years. I mean, the fact is that this guy developed angiostaphylloma, but the optic nerve looks still relatively healthy. And that's an amazing thing. If we can isolate as to why some optic nerves can tolerate high pressures as opposed to a lot of them, we maybe have describing a new treatment modality for glaucoma. And I think that's what Dave Epstein is trying to point out here, optic nerve glaucoma versus the trabecular meshwork glaucoma. But this, so when we talk about glaucoma, the primary etiology may be an obstruction in the trabecular meshwork leading to elevated intraocular pressure, and the end organ damage that you see here is at the level of the optic nerve axons and leading to optic atrophy and loss of ganglion cells and vision field loss. Here is the histology of what happens when glaucoma is not treated. There is a complete loss of axons and this classic excavation of the optic nerve head as is seen in this picture. And these patients are usually blind by this stage. So in terms of genetics, chronic primary open-angle glaucoma, there are 3 genes that have been described, and we went over this in my original lecture, myocilin, opticillin, and WDR36. But all these genes account for less than 5-6% of the primary open-angle glaucoma. So primary open-angle glaucoma is still considered to be of polygenic etiology. The actual gene or genes that are causing this in vast majority of the patients remain unknown. Alrighty, we're back again. Let's continue with the with our lecture on primary open-angle glaucoma. We so far we went through the classification of glaucoma, and we went through the characteristics of primary open-angle glaucoma. Now let's finish the talk with a little discussion as to why we need to talk about glaucoma. Why is it important? And the risk factors associated with someone developing this kind of glaucoma. So why talk about glaucoma? Primary open-angle glaucoma is a significant risk public health problem. It's estimated that close to 50 to 60 million people in the world have open-angle glaucoma. A majority of them are undiagnosed. Glaucoma, both open and closed-angle glaucoma, account for they're the second leading cause of blindness worldwide, and that's a staggering number that you have right here. Second leading cause of blindness in the world, and it's one of those diseases that left undiagnosed leads to blindness, and 90% of glaucoma is left undiagnosed in the world at this point in time. So a lot of work needs to be done, especially young residents who are listening to this talk. Please concentrate on finding. We don't have a easy technique at this point in time that you can take into the field, i.e. into the rural areas of the world, and make a diagnosis of glaucoma. So there must be a better way of, easier way of checking the intraocular pressure, a simple machine that can look at the optic nerve for analysis and perform vision fields and check the intraocular pressure, all in a rural setting. So if one of you can come out with that kind of a simple tool that people can take into rural Africa, rural India, or China, I think you will be detecting a lot more glaucoma patients out there, and that will translate to early treatment and hopefully prevention of blindness. So remember one thing, progression of glaucoma is preventable if it's caught early. Multiple studies have shown this, but the first one that I like to quote in this regards is the paper, classic paper written by Grant, Martin Grant in 1982, wherein the paper is addressed as to why do some people go blind from glaucoma. It's a retrospective analysis of patients blinded by glaucoma. He took a whole bunch of patients who were admitted into Massa, India, and he looked at, everybody got operated, and he looked at their outcomes. And what they found is that those with worse initial presentation, meaning worse vision fields and worse optic nerve damage, had a higher risk of going blind despite treatment, and did so at lower intraocular pressures and thus needed to have lower target IOPs. What Dr. Grant is pointing out here is that the average intraocular pressure for you and me with no glaucoma is 16 millimeters of mercury plus or minus 3, right? If you have somebody with glaucoma, the treatment that a lot of people, or the target pressure that a lot of people used to aim for in 1980s and even into 1990s and early part of 2000 was to lower it below 21 millimeters of mercury. And what Dr. Grant showed in this paper is that that is not sufficient. If the patient presents to you with intraocular pressures, presents to you with advanced vision field loss and advanced optic nerve damage, pressure of 21 is not good enough. Even a pressure of 18 may not be good enough. And so these patients, you want to reduce the pressure closer towards 10 and keep it around 10 if you want to maintain that vision field that they presented with. Okay, even though this is common sense now, it is accepted by most glaucoma specialists throughout the world. At that time, when Dr. Grant wrote this paper, it was a kind of a revelation. So the credit goes to Dr. Grant. to bring in this concept of target intraocular pressure. So you set a target intraocular pressure, and I'm writing here T and underlining, circling that. T stands for target. So every time you see a patient with the glaucoma, your job is to look at the optic nerve, analyze their vision fields, and based on the damage that's already existing there, you decide what the target intraocular pressure is. For example, if a patient presents with ocular hypertension, all you need to do is to bring the pressure down around 21 to 18 or so, and the patient probably will do well for the rest of his or her life. On the other hand, you take a patient with moderate glaucoma, you certainly want to bring the pressure down below 18. And if the patient presents to you with advanced glaucoma, and I went through the definitions of all of this with examples earlier in the talk, what you want to do is to lower the pressure, target intraocular pressure closer towards 10. And once you have the target intraocular pressure in mind, now you go about designing how to achieve the target, right? It could be medications, it could be laser, it could be surgical intervention. And when it comes to surgery, one thing that you have to remember, do not hesitate suggesting surgery when there is a need. A long time ago, Tom Hutchison, my mentor in Boston, said that the hesitancy on the part of the surgeon or on the part of the patient, if to accept surgery or perform surgery, is like the biblical snake waiting to bite you. And if the patient, you suggest surgery and the patient says no to it at that point in time, or you mentally hesitate because you don't have the skills or you're too scared of complications, etc. For whatever reason, you don't perform glaucoma surgery when it is needed. These patients are doomed to go blind. So please learn the surgical art of glaucoma. We have come a long way from 1960s and 70s and 80s in our surgical techniques, and perform appropriate surgical technique to bring the pressure down to the target that you have in mind, so we can potentially save the vision in these patients. And of course, emphasize the importance of early detection and patient education on long-term consequences of poor adherence to treatment regimen, right? And that goes hand in glove. You got to talk to your patients, get their confidence, because it's a lifelong association between you and your patient. Glaucoma is not one of those ocular diseases where you see the patient once and do the surgery and never see them again. And that doesn't work in glaucoma management. You will be seeing these patients for the rest of their lives, and so you need to have a good understanding of what the patient's background is. Try and educate the patient in a language that they understand. And so the risk of blindness is emphasized to them should they discontinue the treatment. The other important study that I think you have to read is about the old study, the ocular hypertension study that came out more recently, wherein they followed patients, 600 odd patients with ocular hypertension, and randomized them into treatment and no treatment group. And what you find there is that when there is a 22.5% reduction in the intraocular pressure, they found that it's protective to the optic nerve and prevented conversion of ocular hypertension to glaucoma-related optic nerve damage. So the overall risk of progression to glaucoma in this study was 9.5%, and it decreased from 9.5% in the observation group to 4.5% in the treated group. And the highest risk of conversion to glaucoma occurred in patients with a higher IOP and a thinner central corneal thickness. And they also identified a thinner central corneal CCT, or the central corneal thickness, as an independent risk factor for patients to develop glaucoma. Patients with larger vertical cup-disc ratio were more likely to convert to glaucoma. Important points for you to understand. So when you have a patient with ocular hypertension and the patients have high IOP, here by definition we're talking about 23 or higher, and thinner central corneas, and they have family history of glaucoma, and they have a vertical cup disc ratio that is greater than 0.7 or so, 0.8, with thinner rims. Say African American heritage on top of all of that, I think you should convince this patient to get treated in the hope that they will not develop glaucoma as time goes on in the future. So the risk factors for somebody to develop primary open-angle glaucoma: elevated intraocular pressure greater than 21 millimeters of mercury. The higher the intraocular pressure, the more likely that they will sustain optic nerve damage. Central corneal thickness, thinner it is, the more likely the damage that can happen. Positive family history, we talked about this. Advanced age, as you grow older, likelihood of developing glaucoma increases, and African American heritage increases the risk of developing glaucoma compared to Caucasian population. And these are the disc changes that you're looking for in patients with glaucoma. Glaucoma disc cupping that reach disc margin. As you can see in this particular case here, the disc is, there's no margin left, as you can see. I mean, most of the rim is all eaten away by glaucoma-related damage. And so this is almost like 100% cupped out optic nerve. Bending of blood vessels at margin. Please watch out here. In this example, you will see two signs of glaucoma. You can follow this. You can see the blood vessel is bending and then coming out. This is what I watch for. Where the bend happens is where the cup is ending. Don't mistake the central pallor to be the entire cup. The cup is going to end where the blood vessels are bending up, and that's where you demarcate the rim is ending. And of course, you have this disc hemorrhage or the transhemorrhage, which also goes in favor of glaucoma. Saucer-like depression of the cup, which is more likely to occur in normal tension glaucoma. Splinter hemorrhages, like I just pointed out, and beta zone peripapillary atrophy that we talked about in one of the previous lectures. Okay. Age, again, is an independent risk factor. It's 11% incidence of glaucoma by the time you hit 80 years of age. Vision field defects are 7 times more likely to occur in patients older than 60 years of age compared to younger patients less than 60. And in the old study, the likelihood of somebody developing glaucoma was found to be 43% higher in univariate analysis and 22% in multivariate analysis per decade of age. So age certainly is a risk factor. As older population, the likelihood of glaucoma increases. And that also brings into your attention that in the US, the baby boomers are all aging, which means more and more of these baby boomers are going to develop glaucoma. Worldwide, people are living longer, and as such, incidence of glaucoma worldwide is also bound to increase. And so it is our job as ophthalmologists to screen all the patients that walk through our doors for glaucoma and detect glaucoma at an early stage and treat them appropriately. Black African American heritage, like I mentioned, there are 3 to 4 times greater risk of developing glaucoma compared to Caucasians. So are also the Hispanic and Latino population. Blindness is also 4 times more common among the African American population. Primary open-angle glaucoma diagnosed is diagnosed. This is among the African Americans. It's diagnosed at a younger age and at more advanced age compared to Caucasian population. So there's definitely a racial predilection for African American descent population to develop glaucoma. They're much more prone to develop damage to their optic nerves, and they're much more prone to develop glaucoma at a younger age compared to the Caucasian population. Family history increases the risk of glaucoma by 3.7-fold. And so if you have a brother or sister with glaucoma, your likelihood of developing glaucoma is increased by 3.7 times. Other associated risk factors: myopia, diabetes, cardiovascular diseases, and remember, primary open-angle glaucoma or ocular hypertension is a risk factor. for central retinal vein occlusion. So anytime you see somebody with central retinal vein occlusion, always check the pressure in the other eye. Why is that? When you have a CRVO, automatically because of compromised blood circulation, the intraocular pressure initially at the time of presentation is decreased in that particular eye. So if you want to see if this patient has underlying glaucoma that preceded this attack, concentrate on the normal eye, the unaffected eye, and see if the intraocular pressure is elevated. So it's mandatory, in my opinion, for you to investigate and look into the unaffected eye to make sure that the patient does not have glaucoma. The other important thing that I want to bring to your attention is myopia. Myopia and glaucoma, it's a kind of a love-hate relationship. I mean, some books indicate that myopia is strongly associated with it, some as moderately associated, some as mildly associated. In my own experience, if you have glaucoma in a myopic eye, these eyes have to be treated specially. And you don't take care of this. The reason why is that the optic nerve, I think, is much more susceptible to damage compared to somebody with who is not a high myope. So high myopes and elevated intraocular pressures, treat these patients kind of aggressively, and if they need an operation, you got to take certain precautions. So we will talk about this when we do the surgical lectures, but it's sufficient for me to mention here that hypotony maculopathy is a high risk in these patients. So generally try and avoid doing a trabeculectomy in the high myopes. They have thin sclera, so it's like puncturing a balloon, and the sclera can collapse inwards because it cannot withstand the force from the inward force that's being exerted by the extraocular muscles. All these extraocular muscles. I'm trying to draw the superior rectus here, and you have the medial rectus here, and you have the lateral rectus here, and the obliques, and so what happens is this. If you do, if the sclera is thin and you lower the pressure inside the eye by just say by doing a trabeculectomy operation, the inward pressure that the extraocular muscles are exerting on the globe, they're gonna they're going to flatten the bottom of the eyeball and throw the retina into folds, causing maculopathy, hypotony maculopathy, and the patient's vision will take a hit in this situation. So it's a fine line that you walk in terms of controlling the pressure in this particular group of patients. Canal surgeries, in my experience, works very well in this patient population. Try and avoid doing full thickness trabeculectomy operations in these patients. In any case, I think you need to handle these patients with myopia as a special category and treat them appropriately. The other group of patients that you need in the same context to treat gingerly are patients with the optic nerve head drusen. Disc drusen patients, you got to treat those patients aggressively. Okay, this is another group of patients who can lose their vision rapidly if you don't control the intraocular pressure, and that's to do with the fact that these axons are caught between the rock and whatever the saying is. So you have calcium deposits in between the fibers, between the axon fibers, and now you expose these fibers to elevated intraocular pressure that's bearing down on them from the eye or from the vitreous cavity down. What's going to happen is that I believe the axons are going to be much more under pressure, and I've seen a couple of these patients rapidly lose their vision. I remember 10 years ago, I had a patient who presented to me with double arcade scotoma. Intraocular pressures were like 18 on medications when he came in, but he already lost a significant amount of vision. I operated on this patient, brought his pressure down to 10, but in spite of that, over the next 2 years, he lost his vision down to hand motions, and I haven't seen him in the last few years, probably because he lost faith in my treatment options. And unfortunately, they could not do much. Talking to people who have been in practice longer than me, especially Del Carwell, our chair here at Tulane, he had similar patients experience in the past. So be aggressive when you're treating patients with disc drusen, and also treat patients with myopia aggressively. Let's move on to the next topic, so prognosis. So what happens to these patients in the long term with glaucoma? Most patients with primary open-angle glaucoma actually retain useful vision for majority of their life. Blindness is seen in 27% of the eyes as a unilateral instance and 9% bilaterally at 20 years after diagnosis. So, on an average, give or take 10% of the patients are blind bilaterally at 20 years after diagnosis. Bilateral blindness is higher among the black population here in this country compared to white population, 8% versus 4%. Vision field loss at diagnosis have higher risk of blindness, meaning if a patient, when the patient presents to you and the patient has, say, double orchid scotoma with pressures of 30, compared to another patient who presents with pressures of 30 but vision field is perfectly normal, the guy with double orchid scotoma at presentation is more likely to go blind in the near future or in the next 10 years compared to the guy whose optic nerve withstood those pressures and has completely normal vision fields. So you got to treat those patients with vision field loss at presentation much more aggressively and lower the pressure more. And multiple studies have shown that if you lower the intraocular pressure below 18 at all visits, the likelihood of progression of a moderate glaucoma and even severe glaucoma is much less. But advanced glaucomas, we want to lower the pressure even more to less than 15, closer towards 10. So again, I want to introduce the concept of target intraocular pressure. Target as in TIOP. Okay, when you look at these patients, make up your mind based on the damage that these patients are presented with. You want to make up your mind as to what the target intraocular pressure should be to prevent future damage. Write it down in the chart. Mention that to the patient that this is what I'm trying to aim for, so they understand what you're trying to achieve, and then go about your management. So I conclude this lecture by giving you two things to read. One is the grant paper that I mentioned here. Why do some people go blind from glaucoma? And the other paper that I want you to read is the Oates trial. And I think these two papers should shed some light into your understanding of primary open-angle glaucoma and treatment options as to why we're doing what we're doing. Okay, so that concludes today's lecture. And as usual, I want to thank all of you for listening to this lecture. Please look out for more lectures on MediTread YouTube website every week. It's my goal to post a lecture. And also look out for our CME and board review courses, which are upcoming. I believe the next one is going to be in December. If you have any comments, you can post it on our YouTube site or send an email at ayala@meditread.com or ayala@tulane.edu. Would love to listen to your comments as to how we can improve. If there are any particular topics that residents from other parts of the world would like to listen to, please let me know, and we'll try and see if we can organize a lecture around your request. Thank you, and God bless.